In this video, we're going to discuss what a chronic illness is and how it impacts a child and the child's family and the stages of those reactions. There are some varying definitions for a chronic illness, but generally they all include some length of time. 3 months is a common cutoff. And they all include something about impact. So one definition would be a condition or illness that interferes with daily function for 3 months or more, or instead of interfering with daily function, you could say that it causes frequent hospitalizations every year. Or we also include conditions here that may not be bothering a child yet, but they are progressive diseases and we expect them to do so in the future. Generally speaking, it's any condition that affects a child repeatedly over time. Let's take a look now at what some of those impacts might be. For the individual child who is affected by the disease, their reaction to that diagnosis heavily depends on their developmental stage and abilities. So imagine, if you will, an infant. Their entire experience of that disease will be based on what happens to them. Remember, they're in that sensory motor stage, so there isn't much cognition, just the experience of things like pain or separation from parents. For the toddlers and the preschoolers, they really don't have much understanding of what's going on, but they do remember patterns. So they may cry every time you go to the hospital because they remember that that's where painful things happen. Or they may start to act out when they start to feel sick because they know then they're going to have to go to the hospital. So there is a lot of pattern recognition there. But their understanding of what the disease is and how it works may be very skewed, and they may think that they caused that illness by something they did or something someone else did, rather than understanding germs or genes or cancer or anything like that. For the school-age children, they understand better what's happening and are eager to start learning about their condition, whatever it is, even if they're not quite ready to be fully independent in the management of that condition. However, they are more interested in being at school and being with their friends, so anytime they have to stay homesick or be admitted to the hospital, that is more vexing to them. And then finally, with the adolescents, we should be trying to transition the adolescent to independent management of their condition. But remember that adolescents have that invincibility fable tendency, so sometimes they will neglect their personal care because they don't believe that anything really all that bad will happen to them. Of course, fitting in with peers is also very important at this age, so being different can be a real trial for them. Now, for any of these stages, this is only if the children are following typical growth and development milestones. So, for example, with some chronic illnesses, we never expect the child to advance much beyond a toddler or preschooler mentality. So they may never experience a true school age or adolescent reaction, even if they hit those ages. The visibility of the problem can also affect how the child reacts. For example, someone with a facial deformity may have to endure much more bullying than someone with diabetes who visits the nurse's office every day at lunch and misses some school here and there, but otherwise has no visible ailment. Parents have their own reaction to the diagnosis of a child with a chronic illness. For many parents, they actually begin by grieving the loss of what they would consider their normal or healthy child. Managing a child's chronic illness also adds a lot of demands on the parent's time and energy and even finances. So there can be a lot of stress in the family and between the two parents as well. Single parents, of course, have an even greater stress because there is no other parent to help share that load. Think especially if one child needs to be hospitalized but the other children are fine. What do you do with that other child? So having some sort of support system is key for a family surviving a child's chronic illness. Another reaction that parents may have is overprotecting the child. So we can see this in two main ways. The first is they don't allow the child to do anything because they're afraid it's going to hurt them. So maybe someone with diabetes is not allowed to participate in organized sports because their parents are afraid their blood sugar will be affected. Well, we know that we do have athletes who can effectively manage those blood sugar changes, so that's an irrational response. The other form of overprotection we often see is a lack of discipline or structure in the child's life, where the child can pretty much get away with anything because the parent pities them, feels bad for them because of what they have to experience. A final unintentional impact is that parents become experts in their child's condition. And as healthcare providers, we can't afford to overlook this. So if you are caring for a child who does have a chronic illness, please acknowledge how much the parents know about that condition and recognize that they know the child's particular habits and reactions to particular treatments from past experience. And while we may know about the disease in general, we don't know about this specific child's experience. So involve the parents as much as they are willing to be involved. Allow them to provide as much care as they'd like to. But of course, don't forget that sometimes parents need a break and will welcome the chance to have you take over some of that care. As families are reacting to the diagnosis of a chronic illness, they often go through some distinct phases of those reactions. So first, before the diagnosis is actually made, we often see a fair amount of anxiety because the parents, the family, the child can tell that something is wrong, but they don't know quite what. So they may think that they are eagerly awaiting a diagnosis, but once they receive the news that their child has a chronic condition that cannot be easily cured, then we see a reaction that's very similar to the stages of grief that people go through. So the first stage there is denial. So stages of grief. First, denial. That's not true. That's not really what's wrong with my child. You must be wrong. I'll go figure out the real answer. And then there's often an anger piece. Why me? That's not fair. What did I ever do wrong to deserve this? And then a little bit of bargaining. Well, I'll just take really good care of my child and then everything will be okay. If I do everything right, really I don't need to worry about this. And then sometimes depression. It's just not working. I'm stuck with this. There's no way forward. And then finally, hopefully, achieving acceptance, which leads to what we call a new normal. So it may not be normal for a typical 3-year-old to get 4 insulin injections every day. But for a family who's been living with that for a few months or a few years, it feels very normal, and that's part of the acceptance piece. Don't forget that with these stages of grief, it's not a 1, 2, 3, 4, and then we're done sort of process, but there's a lot of bouncing around and back and forth, depending on other stress points in the family's life. Some of those stress points include things like when we would expect a typical developmental milestone, but we don't see it. So a child who is 5 years old and does not get to get on the school bus to go to kindergarten, but has to take a special van to a special school. Or a child who's a senior in high school and is not invited to the senior prom. Or an 18-year-old who has finished their 12th year of school but isn't actually graduating. They're going to stay in school until they're 21. On and on and on. Also, a stress point for child and family is often puberty, whenever that occurs. If it's a physical condition, the hormones can greatly impact the nature of that chronic illness. Or in any case, there's suddenly a massive growth spurt. So if the parents are trying to assist the child with activities of daily living, with hygiene, or if the child can be violent, then suddenly this much bigger, stronger child makes daily care more of a challenge. Of course, as we mentioned with Down syndrome and other cognitive issues, often the biggest stressor is what's going to happen to my child in the future, especially when I'm gone. The repeated stress and the bouncing around through the stages of grief can lead to a condition that we know as chronic sorrow. And this is just long-term, periodic sorrow. So periodic meaning that sorrow comes and goes, ebbs and flows. So this could affect both the child and the caregiver, even siblings, anyone in the family. And it's very cyclic. So I'm doing really terrible when my child is first diagnosed. No, I'm kind of getting used to things. I'm really feeling good. Oops, something stressful just happened. I'm coming back down again. So you get kind of this up and down or roller coaster that parents describe as their emotions ebb and flow. There can be internal or external triggers. So maybe somebody bullies the child. That would be an external trigger. Or maybe the child realizes that they may never have children of their own. That would be more of an internal trigger. There's also just a sense of loss or disappointment with this chronic sorrow. And it can progress if the patient, the family member, whoever is affected, doesn't have a pattern of positive coping mechanisms in place. The sibling response to a chronic illness is, of course, also dependent on the developmental stage of the sibling and what kind of age difference there is between them and the affected child. But we do know that there are some common patterns, especially for young children who are fairly close in age to the affected child. So one thing is that the imagination can run wild and exaggerate the extent of the condition, especially with younger children who, for example, hear that their brother had surgery on his leg and they just imagine that his leg was cut off. So the first thing we need to do is make sure that the sibling accurately understands everything that's going on. And usually this means we want to allow the sibling to visit the affected child and interact with the affected child as much as possible. Although if the affected child is intubated, unconscious for some reason, then very young children will not understand, and maybe looking at pictures and remembering stories together would be a better way to involve that sibling. We also know that there may be some jealousy. I can tell you a personal example. My younger brother has cerebral palsy, and when he was in first grade and I was in fourth grade, he went for physical therapy and doctor's appointments quite frequently. And I didn't understand that physical therapy was painful or that he didn't enjoy going to the doctors. I just saw that he got to miss school a lot. And actually, they went out to eat a lot of times after those doctor's appointments too. So I was jealous of all of the special attention and special activities that my brother got, instead of recognizing what a challenge that this experience must be for him. So Again, we want to make sure that the siblings understand the affected child's perspective, but at the same time, we can encourage parents to make sure that they're spending special time with all of their children instead of only focusing on the affected child. In fact, sometimes the siblings may truly be neglected if the affected child really does require 24/7 care. In which case, we want to work with the families to figure out if we can create some sort of support network to help care for the affected child so that the parents can share their time and energy with all of their children. In addition to arranging for care of the child, there are plenty of nursing interventions. So, of course, remember the first is always to assess the situation and figure out what needs the family has. Do they have financial needs? Do they need specialized equipment to care for the affected child? Do they just need some emotional support? Do they need education? So once we determine the family's needs, then we're able to either provide the service ourselves or connect them with our interdisciplinary partners who are able to provide that service best. We know families will need emotional support and education, both at the time of diagnosis. So we can anticipate that following diagnosis, there is going to be an intense period of need, and so we should anticipate following up with that family frequently, even if it's just via telephone call instead of requiring them to come into the clinic. We also want to support whatever decisions the family is making. So sometimes this is very easy. We fully agree with the family's decisions, but other times we would do something differently, but we need to acknowledge that it is the family who is experiencing this. Remember that the family are the experts in the care of their particular child, and so we need to support them and help guide them through whatever other resources they need to make that decision a reality. And then finally, we want to make sure that there are coping mechanisms in place. So we can ask what coping mechanisms the family already uses, and then we can encourage some other coping mechanisms. For example, support groups can be very helpful for the parents, for the affected child, or for the sibling. We also know that there are programs that offer respite care, where parents can bring the affected child to a residential place or even just for an evening and allow the parents to either take the siblings out for a fun evening, or the parents can go on a date, or maybe the parents just need to go grocery shopping. So we want to make sure that parents are aware of those resources so we can help connect them. Finally, the last most important thing for all of the family members is to provide a sense of control whenever possible. For the hospitalized patient, a lack of control is often their main complaint, and with a chronic illness, that same loss of control may apply to everyday life. So as much as possible, allowing the child or the parents to make even silly little decisions, such as what they want to eat for lunch that day, or what time they want to take a bath that day. That will just help to protect their mental health and encourage positive coping as they try to get through this. As a part of the education that we provide to families at the time of diagnosis, there are a few things that we need to focus on because we know families often forget to consider them. So first of all, activities of daily living. That should be fairly obvious to you, that the families may need some instruction on how to provide assistance for the child. Maybe the child needs the instruction because they're old enough to be managing their own condition, whatever it is. So just making sure we sort of walk through a regular daily schedule with the family and provide them with structures and patterns to follow to keep them on the right track. For some patients, we also need to think about transportation. Now, depending on what the chronic issue is, this may not be that impacted, but if there are mobility issues and there's a wheelchair involved, then we need to consider a wheelchair accessible vehicle. If there is a significant lack of tone, we need to consider specialized car seats to help maintain the skeletal integrity in case of a car accident. Sometimes we have patients who are on ventilators, and then we need to consider how we can supervise the patient on a ventilator while they're traveling somewhere. So the parent can't be driving in the front seat, ignoring the child in the back seat. We need an additional driver, or we need an additional caregiver wherever we would go. And speaking of trying to get places, we can address primary care with the family. Usually someone diagnosed with a chronic illness will be diagnosed or followed by a specialist, an endocrinologist, an orthopedist, a neurologist, but we need to remind them that they still need to be visiting their primary care provider regularly for immunizations, for developmental milestone checks, and just to help coordinate all of the specialists that may be involved in the child's care. Finally, at some point, usually not at diagnosis, usually a little later on, we spend some time discussing realistic goals with families. Now, to be clear, these are goals, not dreams. Your dream can be whatever you want, but when we're helping a family set a goal, we want to make sure it's realistic. So, for example, if we have a child with a significant cognitive impairment, they can dream about becoming President of the United States one day. I can't say that's never going to happen, but it's not the most likely thing to happen. So, being the president can be your dream, but when we talk about goals, maybe a great goal to work on right now is learning to write your name. And then once you've mastered writing your name, maybe you can learn to read little chapter books, or etc., etc. So remember, with goal setting, we want them to be specific, we want them to be measurable, we want them to be attainable, we want them to be realistic, and we want to put a time component onto that goal. Let the kids dream whatever they want, but when we're actually tracking progress, make sure you're using SMART goals. Okay, let's wrap it up. Quiz yourselves. What's the definition of a chronic illness? How might it impact the individual? How might it impact the parents or the siblings? And what kind of nursing interventions should we keep in mind? As always, send me an email or let me know if you have any questions.